Good morning, everyone. A warm welcome to all the delegates, faculty members, and guests who are present over here and, of course, online. Let's begin the day with welcome address by none other than our visionary leader, Dr. Guru N. Reddy, sir, Chairman and Managing Director of Continental Hospitals. He established the institution with a vision of world-class patient care and clinical excellence. A graduate of Usmania Medical College, he pursued advanced training at the prestigious Baylor College of Medicine, Texas, and built a distinguished career in the USA, serving as a chief of staff for multiple hospitals and later becoming the first Asian and Indian president of the 110-year-old Harris County Medical Society. Recognized globally for his expertise in gastroenterology, liver diseases, and advanced endoscopy, Dr. Reddy has led groundbreaking work in IBD, hepatitis, and NAFL, and functional GI disorders. His unwavering commitment to research integrity, compassionate care, and medical leadership has made him one of the Hyderabad's leading gastroenterologists and a visionary in modern healthcare. Unfortunately, he is not present for today's event, but he is going to welcome all of us. Although he could not be with us in person today due to prior commitments, we are fortunate to have a special recorded message from him. Let us now take a moment to hear from Dr. Guru, sir.
Good morning. I'm Dr. Reddy, Chairman of Continental Hospitals, and I'm indeed privileged this morning to speaking a few words and welcoming all the delegates to the Neurosonology conference, which is being organized on behalf of the Neurocritical Care Committee or Society of India. Dr. Ramesh, who is our critical care head at Continental Hospitals, has taken this leadership to organize the Neurosonology conference in our premises. It's indeed, once again, a true privilege for having this particular session of your Neurocritical Care conference in Continental Hospitals in Hyderabad. It's extraordinarily important from my perspective as a physician and as a clinician, and being associated with a very large tertiary care hospital like Continental Hospitals and spending a great chunk of my life in one of the largest medical centers in the US in Houston, Texas. I understand the importance of neurocritical care, and which I've been emphasizing for the past dozen years in our ICU, and having a constant dialogue with our critical care doctors along with our neuroscience team members. We are very happy and to have a great faculty at Continental Hospitals, the neuroscience department, comprising almost 7 to 8 consultants, along with 5 to 6 other support staff in the form of residents in neurology, physician assistants, technicians who are involved in the day-to-day activities, both in outpatient care as well as in inpatient care. Now, the foundation of neurosonology, I don't have to go into the details, just like many things else has evolved in medicine, that has been very progressive in terms of application of techniques for better diagnosis, for prompt diagnosis, for accurate diagnosis, and in the process, helping the patient, recover properly is the primary objective. So from the perspective of using ultrasound in the world of neurosciences, is not something new. It has been in vogue over the past several decades. And here in India, too, some of the premier institutions across the country have been using them. And we at Continental have been using for quite some time to the extent of what is available and how it benefits the patient. So neurosonology, essentially, what I understand is use of ultrasound evaluation of patients with either brain or spine and cerebral circulation disorders, peripheral nerves and muscles. So this is, in fact, a very vast anatomical area where one needs to develop that expertise in terms of not only doing, but also interpretation. United States of America, we have neurosonology technicians who often are associated with the Department of Radiology or Interventional Radiology, or sometimes they're directly associated with the intensive care units. So every major institution does have this facility, and often these people are paid by the hour in terms of their reimbursements. So this is a great initiative that India is taking in terms of training people and bringing them to speed in understanding the applications of ultrasound in taking care of patients with neurocritical illnesses. I have seen many a time here at Continental Hospitals how it makes a difference, whether it is in terms of management of a patient with stroke, management of a patient with raised intracranial pressures that can happen from a variety of diseases, or management of a patient with trauma, polytrauma, or post-operative situations where such technologies have come to be helpful in terms of proper guidance and and management. Always keep asking our doctors, "Hey, listen, what is the latest and greatest out there that we should be incorporating as a tool, to help our patients to be more precise and avoid any catastrophic events or something that can cause an impediment in the recovery of that patient is very important." Now, in Indian perspective, Western countries have really mastered these things, and they have an extraordinary knack of putting them together and either organizing as a society and offering training courses and certifying people, which has which does over a period of time turn into a commercial agenda. I think in India, with such extraordinary talent, which I'm extremely proud in spite of spending 4 decades in the US, what I have seen in this journey of mine here at Continental Hospitals, our physician talent is extraordinary. Our doctors have incredible capability of learning things at a very fast pace. And we have, just like anywhere else, a large variety of subspecialists. In this particular situation, one can have a trained radiologist, an interventional radiologist, a critical care specialist who has a great interest, or multiple critical care specialists, or anybody from the Department of Neurosciences who can participate in learning the techniques of neurosonology. So, coming back on organization and how we really kind of uplift this in terms of spreading this knowledge and training, large number of people is exactly organizing workshops of this nature, and the incredible faculty who's participating in this workshop, who was going to demonstrate and share their knowledge with the participating delegates is an important feature in terms of learning. So I would like to see more of this happen across the country. The European Society of Neurosonology and Cerebral Circulation, which is well established several years ago, or probably a decade ago, does offer certification courses. But these kind of certification courses, often within a span of few days or a week, is not something that just having a certificate that makes somebody an expert. Workshops of this nature, which are repetitive, which are focused, which are done by experts who are giving the time, who have an academic interest, and who have the interest really to carry our country forward, so that tomorrow we should become one of the certifying societies across the world. I would like to say that, see that day in India, that not only in the world of neurosonology, but in many other specialties and subspecialties, our organization should become the leaders where others across the world will participate and come to learn here. So that will be the day that we truly can say that India has has risen, and it's an advanced country in terms of medical management and in terms of patient care. Now, one other thing that I want to highlight before I close is the advent of artificial intelligence is extraordinarily important. We know that every new gadget or every new technology in today's world that is being introduced, the buzzword is this is AI integrated. So we do not want to be dealing with equipments which are archaic and struggling to learn them, which would not have, a reputable application for the diagnosis or management of a patient. So we should be abreast of technologies and look into what AI is doing. So, in the world of ultrasound or in the world of any other imaging device, artificial intelligence integration is leading to better computation standards in terms of measurements. We all know that. When we have accurate measurements and when we have intelligently interpreted, it will avoid the human error. It will give you instant information, and those computed numbers or values will help us at the end of the day to apply very quickly at the bedside of the patient rather than struggling to independently and individually interpret. So stay tuned to gadgets which are being introduced with AI integration into the ultrasound technology, even in neurosonology. Now, contrast ultrasound has been around now for more than 2 or 3 decades in the Western world. And we are also using in certain areas across India. So, one of the newer applications in your world of neurosonology, I am sure there is a role for contrast ultrasound, which would help to better identification of your blood vessels, which are extraordinarily important, and microthrombi or microemboli or vasospasm, and all of these things, which are highly critical in day to day and hour to hour management of the patient. So AI and the contrast ultrasound and interfacing of the ultrasound technology with other imaging modalities, even remote interpretation. So these are all the things which are evolving for better care of patients, whether they're from a stroke or from intracranial bleed or a spinal trauma at the end of the day, or severe peripheral neuropathies, or myopathies. So these are all the areas which the ultrasound beyond the other imaging techniques that we have or technologies like the MRI CTs, etc., or PET CTs, is going to be very helpful. The greatest benefit, I don't have to tell you this, is the point of care. The point of care ultrasound, which can immediately give instant result. And many times patients are unstable. They will not be transportable to the Department of Radiology because of their instability. And hence, the POCUS or point of care ultrasound becomes extremely valuable in terms of assessment and come to a conclusion. So I congratulate once again the leadership of this organization, the faculty from Continental Hospitals, the faculty across the country, which has come in today, and all the delegates who are participating. And my last wish: kindly continue to engage in these regular workshops. In India today, money is not a matter. There are companies which can come forward, institutions like Continental can come forward, but we need a larger pool of doctors who are trained in neurocritical care and particularly in these kind of imaging modalities. Wishing the conference once again a great success. And I thank Dr. Ramesh for giving this opportunity to interact with you all. Unfortunately, I'm not in town. I am away this week, and I was not able to be physically present and say hello to each one of you, and also learn at this conference. I'm sure beyond the didactic lectures and the training, Continental always takes pride in making sure that your lunches or other food events are well taken care of by the organizers. Thank you very much, and wish you all a great luck to the conference.
Thank you, sir, for your wonderful message and encouraging start to the day. So now let's begin our scientific session. Our first session will cover the foundations of transcranial Doppler, which covers physics, anatomy, and types of devices used. So now let's welcome our first speaker, Dr. Rahul Amte, sir, a senior intensivist currently based in Abu Dhabi. With a strong focus on neurocritical care, neurosonology, and point of care, Dr. Amte has become a trusted voice and inspiring intensivist. We are truly honored to have him with us today. Please join me in welcoming Dr. Amte, sir.
Good morning, all. So let us start with our sonology workshop. So my topic is like basics, anatomy, and type of devices which we use in TCD. So these are the some topic of discussion I will be discussing in next 30 minutes. So what is how like TCD, how it works and other things. So most important effect or principle is a Doppler effect. We must have seen in a daily life, like when the car is approaching us and giving horn, the frequency is more, we hear a loud voice, and when it is leaving away from us, the velocity or the sound decreases. So it's the same thing. There is a change in frequency when the source of sound is moving away from us or coming towards us. The Doppler, which actually it was initially used to measure first time measurement of blood velocity by Santomura and Kinoki in 1961, and it was said like an ultrasound blood rheograph. But formally, the TCD or initial phases of TCD came in picture in 1982 by Rune Assault. So why we are so much attracted to a TCD? Because it's relatively portable. We can do anytime, any point of time. We can do in a day. It's non-invasive. There is no hazards. And point of care, like we can repeatedly use it whenever we want to diagnose patients' abnormalities. So it is named as a stethoscope of the brain. So it has been included in multimodal modalities for the patients neuro ICUs. These are all modalities what we use, and is normally we use it TCD for our cerebral blood flow, which is local or the regional cerebral blood flow measurements. Now, there we'll discuss physics. A lot of terminologies are there which are a little bit difficult. So just bear with me. I will try my best to make you understand. So there are some ultrasound modalities what we have seen in ultrasound machines. Okay, there's called a B mode. You must have seen. So it's like a two-dimensional ultrasound images, which is composed of like dots, and which represent the ultrasound echoes what we get when we insonate with a probe. Then second is color Doppler imaging. This allows us to visualize the flow direction, how the flow is of the blood and the velocities within our defined box. And next is power Doppler imaging. So this also gives like a visualization of the blood flow, but in a very small place constricted like near the stenosis or in the plaque. So just it gives the flow of the blood. It doesn't give any velocity or anything. Then B flow mode. We have seen the B mode, and the B flow gives a more accurate a morphological representation of the flow of the blood to the vessels in our entire field what we are insonating. Next what we do normally is a pulse wave Doppler. So it gives a representation or the waveform what we see on the ultrasound machines, and it helps us to record the Doppler shifts in a defined area. Then some description about how the sound waves are. These are the mechanical waves which carries the energy. They cannot travel in vacuum. They need some medium to travel. They are longitudinal waves. They travel in straight line, not in a zigzag. And in the medium, the molecules are like compressed or stretch apart. Now the acoustic property means what the medium does to the sound waves, whether when they travel to the tissues, how the sound waves are modified. And the effect of sound waves, like biological effect of the sound waves to when it travels through medium, like it can cause a thermal energy, it can transmit thermal energy and give rise to thermal issues. Now, there are some physics things, words like acoustic parameter, what we see. First is period. So period is it's a time from start of one cycle to the start of the next cycle. And it's you can see here a period is a part of the first cycle, a unit of the time, and is determined by the source. And it doesn't change with the medium. Small formula like period is inversely proportional frequency. Period is more, frequency is less, frequency is more, period is less. Next come the frequency. What we see, we normally discuss frequency, high, low, and everything. So it's a cycle per second. Okay, it's a one cycle per second. It's called 1 hertz. Typically, our probes, what we use ultrasounds, they have like a 2 to 10 megahertz or up to 2 to 15 megahertz. There again, they are determined the probe. It doesn't change with the medium. And the frequency is most important. Like it affects the penetration and the quality. If we need a better quality image, we need a higher frequency, but the quality image will be better, but the penetration is less. And the audible sound, what we hear now, what we are hearing, it's the frequency is around 20 hertz to 20 kilohertz. And ultrasound is always more than 20 kilohertz. We cannot hear that. Then come the amplitude. It's like a measurement of the size of the wave. How big is the size of the waves? Units are like pressure, densities, and distance. And this is determined by the source, but it changes when it travels to the medium. So when it travels to the medium, the amplitude may decrease. So you must have seen in ultrasound machine the gain. We increase the gain. So when we increase the gain, we increase the amplitude. So that is what the gain is. And it is expressed in a decibel, what we hear, like sound waves and other thing. Then the power is a total amount of energy in ultrasound machine. It's very important. It's also determined by the source. We cannot change it, and it decreases when it propagates to the tissues. Most important thing, this power is high. It's normally when the ultrasound waves propagate to the tissues, the power may get converted to thermal energy, so we need to take care of that. Intensity, it's again the same, the concentration of energy in the beams, the ultrasound beams. It is also determined by the source, and also intensity changes when it travels to the tissues. Wavelength, the most important thing, it is a distance of one cycle, is measured in the length unit. The only parameters which is decided by the source and the medium both. So we can change it, the source and the medium also decides how the wavelength will be. And normally our 1 megahertz probe has a wavelength of 1.54 mm. So higher frequency when we need a proper image, super quality image. Propagation speed, this is also important. Distance the sound travels to the medium in 1 second. The sound, the speed of sound in the body is 500 to 4000 meter per second. In the soft tissue and blood is 15 to 1540. Key facts, like speed of sound in a medium is same always. Speed remains the same regardless of the source. The speed of sound is only determined the medium where it is traveling. So it's to the soft tissue, the speed is 1540. To lungs, it is less because it contains the gas. To the bone, it is more because it's stiff. And the same, it's solid is faster than the liquid and the gas. Now, what are the components of transducer? You must have seen we use a transducer. So what this is exactly? So in the picture, you can see there's a power supply, the transducer, the acoustic insulator, and the piezoelectric crystals, which are in the front. So the transducer, what we use for TCCD, like a transcranial color-coded Doppler, is a 2 megahertz phased array probe, a small probe, your cardiac probe you must have seen. In that, the piezoelectric crystals are concentrated at the tip so that we can have a proper insonation. And we need a low frequency because we need to, the penetration should be more in the skull. So how it works, when we start the power and everything, the electrical current causes the piezoelectric crystal to deform or vibrates, and this produces our ultrasound waves. And these ultrasound waves are delivered to the tissue which we are insonating. And this propagate to the tissue, and from the tissue, whatever we are insonating, the tissue reflects the waves, and these waves are again perceived or received by the piezoelectric, our probe, and then they are transformed in the ultrasound images. So this is very important crux of the TCD, how it works. So the upper picture you must have seen. The upper one is like when the source is coming to us, the frequency is more. When the source is going away from us, the frequency is less. So this also shows two pictures are there. This is our probe, and our main interest in the TCD is we monitor or just see our blood, the flow of the blood in the blood vessels, velocities. So when we use the probe, gives FT is like a transmitted frequency of the ultrasound waves, and when it falls or on the red blood cells, they are reflecting the velocity. The frequency is called a received frequency. So when the frequency, like it depends upon whether the blood is flowing away from the probe or blood is flowing towards the probe. So here you can see the probe is emitting a frequency, specific frequency on the red blood cells. If red blood cells are moving towards the probe, the frequency which is reflected by the red blood cells, it will be more. So received frequency will be more than a transmitted frequency. So on the waveform, you will have positive, like you have a positive above the baseline, you have positive waveform. But when the red blood cells or the flow is away from the probe, the reflected frequency what we get is actually less. So whatever the waveform, we will have a negative below the baseline. So this is very important. So the frequency of the ultrasound beam, when we focus on the object, actually depends upon relative velocity of the moving object. There will be change in frequency is proportional to the velocity of moving object. The frequency is more when it's moving towards us, or frequency is less when it's moving away from us. So this is a waveform what we get on the ultrasound screen. So you may see there's a concentration of more around the baseline. There are a lot of dots are there. So actually these dots are representation of the number of RBCs. So the number of RBCs around the baseline is more, and towards the periphery, the number of RBCs are, the velocity of the number of RBCs are less. So it shows like the amplitude of whatever the waveform what we give is determined by number of RBCs having a specific velocities. So these are like a spectral waveform which are formed by all the velocities, like there are multiple waves or the graphical representation and of the specific velocities of the RBC, and then they form a spectral envelope. And with this envelope, we can determine the different indices like systolic, diastolic, and mean velocities. So this is a typical screen of the conventional TCD. So on the top, you may see there are few parameters like gain, scale, power, sample, and a filter. So what is gain? So gain is like I discussed previously, is amplification of the poor waveform. If you are not having poor waveform, we increase the amplitude. So we can amplify the signals what we are getting. Sample volume is the volume of the tissue you are insonating. It's normally 12 to 20 millicubic. Power of the ultrasound waves, it should be around like less than 400. When you are doing transorbital, because the power is more, it get converted to thermal energy, and there are some tissues in body which are sensitive to thermal energy, like the orbital tissues. So when you are doing a transorbital examination, the power should be reduced like less than 10% or less than 70 watts. Filtration is we filter a lot of unwanted or amplitude artifacts. Is range from 0 to 430. And the scale. So scale is like what we see on the y-axis, the velocities, and this is the velocity time graph, and it shows the waveform. And here you see different parameters. These are the peak velocity, mean velocity, and the facility index. And downstairs, this window is like is a M mode, and it shows the different color modes. So color is red color, means if the flow of the blood is towards the probe, it shows red in color. If the flow of the blood is away from the probe, it shows the blue color. So it shows this is the depth, at what depth we are getting the arterial pulsations. So this shows the depth and the flow directions. Now coming to the anatomy of intracranial circulation, we have read in our MBBS days, the intracranial circulation is divided in anterior and posterior. So anterior circulation is formed by the common carotid artery originating from the aortas. Common carotid artery get divided into external and internal. Internal when they enter the intracranial midcranial fossa. You can see this get divided into three branches: anterocerebral artery, then the middle cerebral artery and the posterior communicating artery on the both side. Communicating artery on the both side get connected to each other with the anterior cerebral artery get connected to each other with the anterior communicating artery. Then comes the posterior circulation. So posterior circulation is formed by vertebral arteries originating from the subclavians, and when they enter the intracranial through the foramen magnum, they fuse and they form a basal artery. Basal artery at the junction, they divide in the posterior cerebral artery both the sides, and posterior cerebral artery get connected with the posterior communicating artery. So in this way, our anterior circulation and the posterior circulation get connected to each other, and the left and right side also get connected to each other, and they form a circle of Willis. This is to maintain our cerebral circulation. If there are issues on a right, left, or anterior or the posterior circulation, the circulation is maintained with the collaterals. Now, how to conduct the TCD examination, more detail we'll discuss during the workshop, but just in a brief, our human skull has four windows through which we can observe our different arteries. First is transtemporal. This is for the TCD, like a conventional TCD machine. So transtemporal is done to the so this is a transtemporal. So there is a small part of the bone of the temporal bone, which is more thinner and lighter, which we can use for insonation to observe middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. Then there are the transorbital window. Transorbital window is for the insonation of the ophthalmic artery and the ICA. And we have transoccipital through the foramen magnum. We can insonate, or we can see vertebral artery and the basal artery, and the submandibular window to the near the angle of the mandible for our extracranial ICA. So these are all four windows we'll be learning in workshops. So these are the two machines what we use actually. First A, you can see a conventional TCD machine. Here you get only waveforms and the distance at what you are inserting the artery. And this is our TCD machine, TCCD, like a transcranial color Doppler. So here you can have different modalities, like you can see the brain structure and the artery actual, the flow directions, and all other things. So there are the conventional, what are differences? So conventional TCD, like is a dedicated machine, you cannot use it for other use. And our TCCD is like a general machine which have TCD software. The transducer needed for conventional there are three different frequencies. For TCCDs is only one phased array transducer. Spectral Doppler are both we can observe. The angle of insonation is not possible in, we'll discuss in the workshop what is angle of insonation. Is not possible in conventional, but we can see in transcranial Doppler. And the most important thing, both can detect microemboli. Availability of this is a little bit difficult, and but in of conventional, but in TCCD it is easily available. Learning curve is more in conventional because you need a lot of practice to do that, and it is less in the TCCD. So TCCD is better because the conventional just provide the velocities. It's blind, you cannot see the artery actually. Identification depends upon the depth, and a lot of manipulations are required. Is also depend upon orientation of probe and everything. So our color coded is better. It gives anatomical structures. It's easy to identify the vessels, and most important thing is the angle of insonation, which we can use it in TCCD. So this is a cartoon just shows like how it looks like when we do TCD. So this is our probe. This is the ipsilateral side. Suppose you are inserting on the right side, it's the anterior and it's the posterior side. Here the red color is the flow is towards the probe, the blue color is flow away from the probe. So when you are inserting the right side, the right MCA will be red, the ACA will be blue, and the reverse will be the contracted side. And you will be seeing the brainstem, and around that the posterior communicating artery and the PCA. So these are the views what we see on the TCCD. This is transtemporal view. Normally we have two views like axial and coronal views. We normally use axial. So here is how we should insonate. So our cardiac probe is hold above the zygoma in front of the pinna in this side, and we just insonate first to see like opposite. First, we should, when we insonate, we should insonate in the diencephalic phase, where we should see the opposite table of the skull, the other part of the skull, and we should like little bit make it caudally. So these are the view what you get it. So first view, when you see, you should always try to visualize the brainstem on the midbrain. This is a peduncles, cerebral peduncles, and around that peduncles we have a circle of Willis. So first, when you visualize this thing, and then you get this picture. So this is like this anterior side in the posterior side. When you insonate from this side, you will have MCA red color, the AC in the blue color, and this ipsilateral side, and the ipsilateral communicating artery, and the posterior cerebral artery. So this will be a picture what we get normally as like a circle of Willis. So anticirculation, what we see is like in front of the midbrain, like this is anterior side and posterior side. In front of midbrain, we get anticirculation, and around the midbrain, we will have the posterior circulation. Then transforaminal window, how we see, just hold the probe horizontally near the mastoid, and when you insonate properly, we will see a small foramen magnum. This is a hypogenic area where we see foramen magnum, and in that, if you put a color window, and you will see a Y-shaped structure. The two Y's are vertebral artery, and the distally it is a brachial artery, basal artery. So transorbital view, we see for the orbital. Here the insonation, the power should be decreased less than 10%. The probe is placed on the eyelid and immediately and superiorly. The first vessel which you observe is the superficial, less than 6 centimeter is the ophthalmic artery, and in the distally beyond the 6 centimeter you see the ICA. And submandibular approach, just near the angle of mandible, we insonate and to see mainly for the extracranial ICA for a measurement of Lindegaard ratio. So these are some like depth, a lot of parameters of different arteries, like what are the windows, depth, how much depth you get the arterial images, and the flow directions and the color coding. So normally to the temporal, we have MCA, ACA, and PCA at the different depths. And this is like this also shows the velocities, mean velocity and pulsatile index. Normally in MCA, the velocity is like 90 to 110, and there's a maximum, and the lowest is in the vertebral artery, like 52 to 50 to 66. So just a little bit, I think next lecture is about the TCD waveform and indices. So this is what we see on the TCD screen. Like a classical waveform, it's initially there is an initiation of the systole, the peak systole, the diacritic notch, and diastole, and this gives the different velocities, like a systolic velocity, peak systolic, diastolic velocity, and the mean velocity is the area under the one cycle. So these are like peak systolic velocities, and diastolic, and mean velocities, and pulsatile index, and all other things. So mostly this will be discussed in next lecture. So what are the different factors which affect the TCD velocity? So which increases TCD velocities, like vasospasm, hyperemia, hypercapnia, your sickle cell anemia, and preeclampsia. The things, the parameters decrease velocity, or when the ICP is very high, the velocity decreases because of the high resistance. Hypocapnia, and the post-stenotic lesions, and then hypotension, hypothermia, brain death, and other things. So I will just skip this because this is the next lecture. So what are the physiological variables on these waveforms? Like age, the velocities are maximum in 6 to 10 years of age, and slowly over the lifetime it decreases. The velocity is more in women as compared to men. In the pregnancy, all the velocities, there will be reduction, and the hematocrit or hemodilution increases the velocities. So this, I'll just skip this. So how the TCD guided interventions, what we do is when we detect hypoperfusion, we need to improve the CPP, the cerebral perfusion pressure, raise the MAP, decrease ICP, and other modalities. When you see hyperemia, just to identify maybe due to correction of anemia, hypercapnia, fever, and seizures may be the causes. When we detect the spasm, vasospasm, nimodipine, and we need to increase the MAP. So use of TCDs, it's a non-invasive to diagnose cerebral vascular disease. Detection of the occlusions, stenosis, and vasospasms is used for the assessment of collateral circulation and the cerebral vasomotor reactivity, detection of your AV malformations, assessment of feeder arteries and everything. And in most important nowadays, we are TB criteria are there when we thrombolize the patient and when we monitor in the ICUs. You do regular TCDs to see whether there is a restenosis, anything is happening. And pre-procedure monitoring in the carotid endarterectomies, detection of left to right shunts, and in the cerebral circulatory death. So TCD is utilized by different specialties, not only us. Intensive, this cardiologist uses before doing any extracranial carotid evaluations to evaluate intracranial collateral pathways, emboli monitoring. Neurologists for the trauma, aneurysm detection, AV malformation, and vasospasm, and brain death. And neurovascular and neurologist, they are assessing for your collaterals, revascularization, and other stuffs. So there are limitations of TCD. It's mostly operator dependent. So it depends upon the operator, how is trained, how is the level of expertise. The most important limitations is a poor bone window. We don't have in 5 to 10%. We cannot do TCDs because the bone window is not appropriate. Patient should be cooperative. In agitated patient, is very difficult to do. There are dressings when the patient is post-op, dressings, IV lines, and all this positioning is important. And these are other parameters like age, gender, and what we discussed. These also are limitations. And TCD is not a, it's just a global rather than the local parameters for cerebral blood flow. So window qualities, this is 5 to 20% is cranial hyperostosis, and it may depend upon different age groups and ethnicity. So perfect circle of Willis is only in 18% of population. So there are different variations will be there. So we have to take care of that. And a complete circle of Willis is only in 50%. So to conclude, transcranial Doppler, we have only a good opportunity to insonate through this thin bone adult skull. We normally target intracranial arteries. We use low frequency ultrasound. Our main principle is Doppler shift, what we use, but technology what we are using is a pulse wave Doppler. And we get spectral waveform, spectral envelope, and other things through which we use get velocities, and we can use velocities for our treatment modalities. Thank you. Questions? Last. Thank you very much.
My name is Aarti Sangwan. I'm a professor of neurology and division chair of neurocritical care at Virginia Commonwealth University School of Medicine in Richmond, Virginia. In the next few minutes, I will be sharing with you the common core indications of using transcranial Doppler in acute ischemic stroke. I have no relevant disclosures. So by this time, you have a core understanding of how we use the temporal windows, the acoustic windows in the skull, to insonate the circle of Willis. In this infographic, I'm showing the imaging Doppler, which is the echo probe or the phase delay probe. aligned at the temporal windows to look at the basal cistern, the midbrain, and the opposite skull. And then we look at the circle of Willis and use pulse Doppler to identify the vessel of interest, here distal MCA, and use spectral Doppler waveforms to look for parameters, the peak flow velocity, the end diastolic velocity, which are used to calculate the mean flow velocity, which is the hallmark of cerebral perfusion, and pulsatility index, which is a marker for cerebrovascular resistance. Now, in ischemic stroke in general, there are myriad of applications for transcranial Doppler, ranging from outpatient, inpatient to intensive care, or even intraoperatively. I will focus on the very core classical foundation that I can cover in 20 minutes. Moya-Moya disease is another disease process where vasomotor reactivity has significantly changed management. There are implications of stroke risk with regards to diagnosis of vertebral steel, sickle cell, and of course delayed cerebral ischemia in subarachnoid hemorrhages, a core TCD application as well, and brain death. But in the next few minutes, I will cover the ones that are very relevant to acute ischemic stroke, which is detection of the large vessel occlusion itself, collateralization assessment, figuring out which carotid is symptomatic, embolic testing, looking for intracranial stenosis as a cause of stroke, and in post-thrombectomy patients, as thrombectomy is becoming more common, how to reassess recanalization, assessment of shunts, right to left shunts as a cause of stroke, and we'll cover some classical waveforms for these. Now, many people ask, especially in the Western world, why would you need a TCD when you have CT angio, MRI, and now with thrombectomy, we pretty much have digital cerebral angiography in many of these patients who have large vessel occlusion. People have systematically looked at it a few years ago. This study probably needs to be repeated. But despite having TCD capabilities, the use of TCD is not very common because of this perception that it's not added value. So this study looked at about 86 patients and performed TCDs within a few hours of coming to the ED and getting a CT angio or an MRI, and was able to show that additional useful information was gathered in at least 50% of the patients, and it changed management in the patient in 1 out of 6 cases. And the most frequent added information was assessment of collateralization pathway, information related to the patency of the vessel, which is an important information to know in ischemic stroke, and active microembolization, which can help you figure out the cause and the risk of stroke. This was our study that looked at the Wake Forest population in 2017 and looked at both TCDs and carotid ultrasound, and we reported that the notable abnormality with a combination of TCD carotid was really helpful for detection of mobile thrombus, and distinguishing carotid near occlusion from full occlusion, looking at hemodynamic significance of patient with multivessel disease, extra and intracranial stenosis, hyper and hypoperfusion on TCDs, the chronicity, and then there were some abnormalities we found that quite didn't change management, like anterior circulation velocity asymmetry, or when TCD only confirmed what CT angio had already told us, or incidental vertebral steel phenomena. Now, to understand how TCDs can be helpful in ischemic stroke, and we are basically focusing on a large vessel occlusion or microemboli here, you have to know the physiology of why TCD is helpful in showing waveform progression as the vessel goes through different levels of atherosclerosis or other causes of stenosis. So Spencer-Reid curve basically showed how the blood flow velocity changes as the blood flow decreases from right to left, which is completely patent to completely occluded. And we've learned by now that these normal TCD waveforms with rapid upstroke, stepwise deacceleration, robust diastole, with the end diastolic velocity at least a third to half of the peak systolic velocity. When your vessel starts getting stenosed by extramural or intramural stenosis, the diastolic velocity decreases, the waveforms become more resistive, where you have a rapid upstroke, rapid downstroke, and diastole, which is much less than a third of the systole. And then if you see this at a particular segment of intracranial stenosis, a little distal to that, you will have post-stenotic waveforms, parvus et tardus, which is delayed upstroke and delayed downstroke. And these three waveforms are classically the hallmark of large vessel occlusion or hemodynamically significant stenosis, more than 70% of the lumen. We talk about oscillating waveforms. You will not see that typically in stroke. because that's a hallmark of brain death. Now, the progression of these waveforms is actually physiologically correlated to the progression of intracranial stenosis. We are assuming that whatever the cause of the stenosis is, large vessel occlusion coming from atherosclerosis, from plaques, the progression of these waveforms from low resistance waveforms to high resistance to even high resistance can be a very good surrogate of large vessel occlusion. And many people before the CT angio era actually used the TCD waveforms and high resistance waveforms to diagnose large vessel occlusion. And this was again before thrombectomy era and before CT angio became a little more commonly used. In the CT angio or digital subtraction angiography, we have grades of recanalization called the TIMI grades, where you have complete occlusion versus partial occlusion with blunted signal, and then complete recanalization, which is sticky 3. TCD was also used to use TCD based grading called the TB grades, and early studies in 2000s showed that the grade of recanalization diagnosed by transcranial Doppler correlates to the gold standard, which is the DSA. So before CT angio, people used these gradation of the waveforms to diagnose degree of stenosis when diagnosing large vessel occlusion, and you can also use this post recanalization by thrombectomy or thrombolysis to look for how much of the patency of the vessel has come back. So if the vessel is completely occluded, you have no signals, provided you know that patient has windows. So that's always the caveat. But as the vessel starts stenosis, so this is the normal vessel with normal waveforms, this is completely occluded vessel. As the vessel starts getting stenosed, you get resistive waveforms, and then the peak flow velocity decreases, and then you get post-stenotic waveforms or damped signals, and then systolic stumps, and then your flow goes away. So this is if the vessel is occluding, you're using TCDs to diagnose large vessel occlusion. If you're using TCDs to look at recanalization after thrombolysis or thrombectomy, the pattern would be opposite. As the vessel recanalizes, first the systolic flow will be preserved, brought back. Then you'll start seeing blunted waveforms, but throughout the systole and diastole. Then you'll start seeing more flow with higher peak flow velocities and resistive waveforms, and then eventually the resistance normalizes and you will start seeing normal low resistance waveforms with complete recanalization. Now obviously with CT angio and thrombectomy availability, especially in the Western Hemisphere, we don't use TCDs to diagnose LVO anymore, although I will discuss some post-op evaluations in the ICU that we still use TCDs for. But one place where it can be helpful in elective settings is assessment of collateralization. So all of you guys are familiar that the circle of Willis has a very strong will to maintain cerebral perfusion. So anytime there is a occlusion or a traffic block, say in this case ICA on this side, bypasses will be created from the opposite part of the circle of Willis. In this particular case, ICA occlusion is compromising flow in the MCA. So MCA is going to borrow blood from the opposite ICA, and the ACOM will serve as a collateral. So ACOM is the primary collateral. PCOM can serve as a collateral, where MCA can borrow blood from the vertebrobrachial circulation, and then ophthalmic can also act as a collateral, where the external carotid artery through the middle meningeal branches can give blood to the internal carotid artery in case of a blockage. So these three collaterals can be easily measured and evaluated by transcranial Doppler. There are leptomeningeal collaterals which form about 15-17 other channels between the ECA and the ICA. They cannot be measured directly with TCDs, but there are findings on the TCD that you can use to say that there are leptomeningeal collateralizations happening. When we talk about ACOM collaterals, typically what happens is that you have blood flow that is going from the ICA towards the MCA, and it is going towards the ACA. So when you're looking at transcranial Dopplers from here, your blood flow will be towards the probe for the MCA and away from the probe for the ACA. And in case of ACOM collateralization, your MCA will still be blood flow towards the probe. Let me make the color appropriate. So MCA will still show blood towards the probe, But because ICA was blocked and this MCA is getting blood from the opposite side, this ACA is towards the probe and this ACA is towards the probe as well. So if ipsilateral ACA and contralateral ACA are all showing blood towards the probe, that tells you there is ACOM collateralization. Normally, your opposite ACA will be towards the probe, but your ipsilateral ACA should be away from the probe. So here you can see, this is my circle of Willis, this is my MCA, and this is my ACA. And in this particular case, the pulse Doppler is sitting on the ACA, and the ACA is showing negative Doppler shift, flow away from the probe. When I get collateralization through the ACOM, this is my MCA, this is my ACA ipsilateral, this is my opposite ACA, and in this particular case, all the three flows are towards the probe, and the pulse Doppler on the proximal ipsilateral ACA is showing positive Doppler effect. So this is ACOM collateralization. Similarly, you can use ophthalmic artery. Typically, if this is your orbit, flow should be towards the probe, positive Doppler shift, but in terms of EC to IC collateralization, the pulse Doppler here will show negative Doppler shift, flow away from the probe. We can use this assessment of collateralization to look for which one is the symptomatic carotid if we have bilateral carotid stenosis. So, say we have ipsilateral carotid stenosis, this is ACOM collateralization, this is PCOM collateralization, and in this case the flow direction does not change. The velocity of the PCA in this case will be higher than the velocity of the MCA. So say if the MCA velocity is 50, but the PCA velocity would be say 75. Typically, ACA, PCA and MCA velocities have a relationship with each other. The ACA and PCA velocities will always be lower than the MCA velocity. So if the PCA velocity is higher than the MCA velocity, then you can say PCOM is likely collateralized. If that blood flow is not enough, both ACOM and PCOM may be collateralizing, but of course you have to have ACOM and PCOM patency. If ACOM is absent, ACOM collateralization would happen. If PCOM is absent, PCOM collateralization will not happen. This is absence of both ACOM and PCOM where no collateralization is happening, and this is typically the cases where ophthalmic will get recruited. Now, if you have bilateral carotid lesions and the patient is having non-focal symptoms, you can actually use the direction of collateralization to see which carotid is more symptomatic. So the side that is collateralizing is going to be more symptomatic. So in this case, you have say carotid stenosis on this side and then carotid stenosis on this side, but the ACOM is collateralizing towards this side. So this is the one that you will take for carotid stenting or carotid endarterectomy sooner, and you can use a combination of ACOM, PCOM collateralization with ophthalmic to make that distinction. So this is a classical case study that will show how the presence of collateralization can help you figure out that there is a vessel occlusion indirectly. So in this particular case, patient had a M1 segment occlusion and post-thrombectomy basically had early neurological deterioration. This is non-imaging Doppler, and on this side you can see patient had complete recanalization of the M1, and you can see barely the ACA here, but 45 minutes after thrombectomy, the patient basically showed flow diversion of the ACA, and ACA basically became ipsilateral ACA reversed, and that showed that the patient had possible re-occlusion, and this was confirmed by CT, and the patient was taken for thrombectomy. The other place where this can be extremely helpful is emboli monitoring. Whatever the cause of the emboli is, whether you're doing an intraoperative coronary bypass, carotid endarterectomy, now we use embolic protection devices obviously, in infective endocarditis, or you have a known LV thrombus, you have a known carotid thrombus, you can actually physically see the emboli. These are called high intensity transient signals. This is what they look like on imaging TCD, and this is what they look like on non-imaging TCD. So presence of the emboli basically correlates with presence of ischemic stroke, and the degree of emboli will relate to the degree of stroke. And these emboli called high intensity transient signals, you can do this to look for procedural complications. So many vascular surgeons and cardiothoracic surgeons in early 2000s worked with transcranial Doppler neurosonologists to minimize the risk of intraoperative complications by honing their surgical techniques and adding embolic protection devices based on active emboli monitoring intraoperatively. And even one of these hits can be significant, and patients who have hits have 7 times the risk of stroke compared to patients who don't have hits. when you look at intraoperative and postoperative as well, or say elective outpatient stroke evaluation. Embolic phenomena obviously tells you that there is a embolic source somewhere. If the emboli are everywhere, MCA, ACA, PCA, vertebrobasilar, on both sides, then you know it's a cardioembolic phenomenon. It's coming from the heart. If the embolic phenomena is only on the right side, but not on the left side, then there is an embolic source in the innominate or the carotid on the right side. If the embolic phenomena is only in the vertebrobasilar, then it could be cardioembolic stroke as well. So you have to correlate the whole TCDs. Another cause of stroke is intracranial stenosis. Now, classically, just like I told you that hemodynamically significant stenosis causes increase in velocities and then post-stenotic waveforms, in the early part of the stenosis, if you look at the Spencer-Reid curve, your velocities will go up. So here we're looking at proximal MCA and mid MCA. You can see the velocity is 124, which is much higher than normal velocity. Normal velocity of MCA is 40 to 80 centimeters per second. This is an outpatient evaluation of a patient that is having right MCA symptoms, TIAs again and again, especially when they get dehydrated. So here you can see there's a step off of velocity from 124 to 49, and you can say that the patient has hemodynamically significant stenosis. And these are the patients that, you know, if the patient has ICAD or if the patient has another cause for intracranial stenosis, you can escalate antiplatelet therapy based on these findings and follow the patient over time. There are published criteria for intracranial stenosis. The challenge for widespread use of these criteria has been it's very observer dependent. You have to have very due diligence in making sure that you really insulated the vessel very diligently from proximal to distal and looking for that. So most classically, unless you have really good expertise in doing TCDs, my recommendation is that if you're diagnosing intracranial stenosis using transcranial Doppler, stick to more robust changes, which is qualitatively changing the waveform from high resistance waveform to post-stenotic waveform. And this transition basically tells you that the patient has more than 70% stenosis. You're basically inching along the vessel, and proximally you see resistive waveforms, rapid upstroke, instead of stepwise deacceleration, you see sharp systolic deacceleration and diastolic, which is much less than a third of the systolic. And then you see these systolic bruits or murmurs. This is a sign of turbulence. And then if you inch down the vessel, you see post-stenotic waveform, parvus et tardus, just like aortic stenosis. This tells you that there is definite hemodynamically significant stenosis, and I would suggest using robust transition like these to diagnose intracranial stenosis, especially in the absence of other CT angio or DSA. Another use case scenario for transcranial Doppler is right to left shunt assessment. You know, when you have a patient with cryptogenic stroke, obviously finding a PFO, finding a pulmonary shunt can give you an indication that the patient has a thrombotic source somewhere that is doing paradoxical embolism. So the bubble study basically recently looked at robotic TCD, which is now available in the market, to look for shunt assessment with transcranial Doppler with regards to transthoracic echo, and had a subset of patients with transesophageal echo as well, and showed very good results and sensitivity specificity of right to left shunt assessment with transcranial Doppler. Now, how you typically do this is basically you put an IV in a patient. This obviously should be done in a stable patient, and what you'll end up doing is put a 3-way cannula, and you will take about 9 cc's of normal saline, and other would have air, and you withdraw about 1 cc of a little bit of cc of blood, just enough to kind of make a pink contrast kind of a look in the normal saline. So this 10 cc normal saline here, and you will use the other 3-way cannula attached syringe to agitate it, and once you start agitating it, you'll obviously do transcranial Doppler monitoring at the same time. Here we're using the headband to do bilateral monitoring. MCA on each side is typically what we use for monitoring. And then once you've agitated this back and forth, you will be physically able to see bubbles. And once it's adequately agitated, you'll basically inject it. And this patient, of course, does not have emboli. And then about 30 seconds after the infusion of the agitated normal saline, you will ask the patient to do a Valsalva if the patient can participate. And what does the shunt look like? So in this particular video, you can see this is normal TCDs, bilateral MCA, this is MCA-ACA bifurcation, and we've injected agitated saline, and then about 30 seconds after that, you will start seeing some emboli. quite some time. And then you can make sure that the hits, the high intensity transit signals have gone away. So there is a Spencer grading for the shunt as well, for the grades of shunt. But TCD, of course, is very sensitive to look at right to left shunt assessment, and sometimes even superior to thoracic echo, and can be combined with TE to make sure that you've really done a thorough shunt assessment. Or you can have collapse of the collateralization pathways that were earlier keeping the patient intact, and now the patient has lower blood pressure. So lots of quite causes of early neurological deterioration. And post-thrombectomy TCD values actually have been used recently to predict this and actually manage this. Of course, as thrombectomy is becoming more common in India and other countries, this might be a very good use case scenario for appropriate resource utilization, because you can use TCDs by bedside. So this was a recent study that looked at 180 patients with LVO and did TCDs within 48 hours and looked at their peak flow velocities, comparing the ipsilateral and the contralateral side, and was able to predict patients that had high risk of intracranial hemorrhage by higher velocities. And other studies have shown similar prediction of ischemic stroke risk as well. So I hope this gave you a broader perspective of use of very core use case scenarios of using transcranial Doppler. In general, my advice is to do comprehensive assessment. Don't do assessment limited to one vessel, because presence of collateralization, emboli really can be picked up if you do a good patient comprehensive assessment. These are a few landmark articles that I always recommend. The practice standards for TCDs that are almost 20 years old now, but the gold standard for looking at how to use TCDs, how to do waveform analyses, and some point of care applications in intensive care as well. I really appreciate your attention, and this is the website for other educational opportunities and courses that my lab runs. And I hope that you spend more time learning different applications of transcranial Doppler and incorporate them in your clinical practice. Please feel free to reach out if you have any questions. Thank you for this opportunity.
So what is the rationale for doing transcranial Doppler? You must have understood in subarachnoid hemorrhage, vasospasm does not happen immediately after the hemorrhage. It starts around the 4th day, peaks around the 7th day, and it stays there for 2 weeks. So whenever the patient comes to the hospital, he usually comes immediately within 4 to 6 hours or within 24 hours. So you have got an opportunity to record the baseline of the patient. In many of the times, what happens when the patient comes to the hospital, we don't have the baseline like a blood sugar or the blood pressure. Now, the current fancy in medicine is the precision medicine. So, for the given patient, you have the baseline value, and then you can track over the stay in the hospital whether it is increasing or decreasing. And the change in the flow velocity precedes the clinical vasospasm. So you have a window of opportunity to design on your diagnostic, whether this patient requires angiography or not, whether this patient requires a triple H therapy or angiographic management like verapamil or milrinone or nimodipine therapy. So in that way, it helps as a screening tool, and as well as to monitor the patient, whether the therapy is improving the patient or not. So this is what I have telling you, the Bernoulli's theorem. If you see most of the publications in the anesthesia and intensive care, they always say we measure flow velocity and the flow velocity is equal to flow, assuming that basal cerebral arteries, the vessel diameter does not change. But here it is that basal vessels which causes spasm goes into spasm, and then the vessel diameter change. So the velocity is not equal to flow volume. So the Spencer's curve everybody has spoken about, so I am not going into detail again. But one thing you must remember is this is a mathematical model developed for carotid stenosis. Now, and it assumes the vessel is symmetric, vessel is of short length, smooth surface, and a circular narrowing. But in reality, when you see vasospasm, it is a prolonged narrowing, and there is some collaterals, and there is a pressure drop. In the ICU, there is some intervention going on, hypertension therapy, use of nimodipine. So when you measure the flow velocity of a given patient, it is the summation of all these factors put together. But then as a concept, this is useful to understand why the velocity increase or decrease. So sometimes when the vasospasm is very severe, the vessel wall also starts vibrating, and then this gives to two phenomena. That is, one is co-vibration. Co-vibration is nothing but you see a high intensity signal around the zero line. The other one is the mirror image parallel strings. You see that horizontal line here. So these two indicates severe vasospasm. When these are present, the number criteria does not exist. That means you need not have a flow velocity of more than 200 to say that it is in vasospasm. When these two criteria are there, even if the velocity is only 60 centimeters per second, still it is severe vasospasm. If the time permits, I will show you the video. So now coming to the basal vessels and the vasospasm. Vasospasm can occur in any vessel. Suppose if there is an MCA aneurysm rupture, it need not necessarily only the MCA vessel have to go into vasospasm. Any vessel can go into vasospasm. But the flow velocity changes in the MCA are more predictable in case of vasospasm because it is an end vessel except for the leptomeningeal collaterals. But when it comes to anterior cerebral artery, it is not an end vessel. It has a collateral circulation. Sometimes there can be a pre-existent hypoplastic vessels, and it is very difficult to insonate the A2. So the velocity cutoff criteria is very reliable for the basilar artery and the middle cerebral artery. So these are the simple classification. Whenever the velocity increases more than 80, then we consider as a spasm. But sometimes one of the co-founder is the hyperemia. Now, how do we differentiate hyperemia from the vasospasm? You look at the mean flow velocity of the extracranial ICA, and then you see the ratio. That ratio is called the Lindgard ratio for the middle cerebral artery. For the posterior circulation, it is either called the Sustil or the Sviri ratio. Anything more than 3, then that is more suggestive of vasospasm. As I told you, now hyperemia and vasospasm can coexist. So you always look at the flow velocity as well as the Lindgard ratio. So depending upon these two combinations, you can say vasospasm or vasospasm with hyperemia. But what are the bad signs? So any flow velocity which exceeds more than 180 centimeters per second, or between day 3 and 7, suppose you are doing daily, like twice daily, if the velocity starts increasing more than 65 centimeters per second per day, some people say it's 25 to 50, there are different textbooks give the different criteria, a 50% increase. Longitudinal increase. What do you mean by this longitudinal increase? The previous images you have seen the transcranial Doppler from 60 to 40, you see a red band. So the entire thing is the middle cerebral artery. Now you see the flow velocity at 60 millimeter depth. Then you see the flow velocity at 58. Then you see the flow velocity at 56. That is at a different segment of the middle cerebral artery. If you see an increase in more than 80 centimeters per second, that is again an unfavorable sign. Or when the Lindgard ratio is more than 6, or when the abrupt increase in PA at least in more than 2 vessels. So these are all indicators of unfavorable outcome. So one of the most common differential diagnosis is hyperemia. And why does it happen? It can be because of triple H therapy which you give, or there can be some hypoventilation, CO2 buildup, or there is an autoregulatory loss. Sometimes aneurysms are associated with AVMs also. In all these conditions, you can see hyperemia. So what are the criteria? Elevated flow velocity. More important, it is the diastolic flow velocity, low pulsatility index, and elevated venous blood flow velocity, and low PA even in the ICA, and absent dicrotic notch. If you see all these features, then it is more likely to be of hyperemia than vasospasm. So now coming to the practical aspects. In the diagnostic lab, you have a quiet environment, but in the ICU, it is exactly opposite. So lot of noises like the monitor noise and nowadays mobile phone noise, everything will cause an artifact in the Doppler signals. So it is better if you want to really hear these musical murmurs, it is better to use an headphones. Sometimes the bones are very thick, you are finding it difficult to insonate. And if it is an operative case, if there is a burr hole defect, then you can use the burr site also to insinate. But nowadays people have started putting metals and then screws, so it becomes increasingly difficult to use that burr site also. And importantly, the flow velocity apart from vasospasm is decided by the blood pressure, carbon dioxide level, hematocrit, and sepsis. So all these can influence the flow velocity. And if the patient is not intubated, there can be abnormal respiratory pattern, noisy breathing, even that can interfere with your Doppler signals. And then sedation, that itself will decrease the flow velocity because of decreased blood flow and metabolism. So all these factors you must take into consideration before you interpret and jump into a conclusion. So as a screening tool, it is very useful because you can do any number of days. There is no need to shift the patient. But it is better you mark that area where you put the probe so that the same area must be followed up to identify any increase or decrease in the flow velocity. And then you can use this criteria to decide which of these patients require DSA, which of these patients require an intra-arterial therapy, and whether this arterial therapy is beneficial or not post-intervention. And do not make any decision on a single measurement and a single vessel. It is the trend value which is more important. And before interpreting, always consider the systematic factors. And when you identified severe vasospasm and when you operate at that time, then the prognosis is usually bad. But vasospasm does not always equate to cerebral ischemia or clinical deteriorations. In patients who have an associated hematoma, the onset of vasospasm is usually delayed. So instead of waiting for 4 days, it can even happen at 10 days also. So you have to prolong your monitoring period. So a negative TCD value does not rule out vasospasm. There can be other causes for that. One, it is a distal vessel spasm, or if the infarct has already set in, then obviously the flow volume will come down, the flow velocity will also come down whenever the ICP is high and when the collaterals are good. So this was one patient in the ICU where we noted a flow velocity of 191, but the PA was around 0.74. Here you can see aliasing also. This was on the 10th day of SAH. So we thought one patient was already on noradrenaline. So we thought it could be hyperemia. But the surgeon, as usual, no, it is vasospasm. You keep pushing the pressures more. But when you keep pushing the pressures more, what happens is the flow velocity will further increase. So how do we convince the surgeon? No, it is not vasospasm, it is hyperemia. So we monitored the cardiac output. You can see the cardiac output somewhere around 10 liters per minute. Then we did a CT perfusion where the mean transit time was just 2 seconds. In the meantime, the procal value came as elevated. So we treated with the antibiotics and we came down on the noradrenaline, maintained the normal pressure. So after 48 hours, the flow velocity has come down to 110. So it is sometimes in the ICU is little difficult to make a diagnosis or to convince the surgical team also. So these are all, if you are using an ultrasound, there will be two values here. One is the peak systolic and one is the TAP. TAP is the time average peak systolic velocity. This peak systolic velocity is just a single point measurement, whereas the time average peak is at every second it measures the maximum value and takes the average. So in the Raymond machine, it is only the peak systolic velocity, whereas when you use a DWL, that corresponds with the TAP value. You can choose whichever you want, but use that same parameter across the patient on a given day so that there is no fluctuation, because these two values are not interchangeable. So this is typical of hyperemia where you don't see the dicrotic notch. So this is one patient where you can see the peak systolic mean is around 135. This is the extracranial ICA. It is around 25. It is more than around 5 times. So this is typical of vasospasm. You can use either TCD or TCCD, whichever is available with you, you can do it. Okay. So I hope the video plays. There will be background noise of my voice, so don't focus on that. Just focus on the musical note. It will be something like if you are auscultated an asthma patient, there will be small wheezes at the end of expiration. Like that sound you will get. The musical sound at the end. Okay. Here, if you see, the flow velocity is more than like 250 or 300. Okay, but still that number is not the criteria. This sound is more important. And this is using a TCD machine. Here the flow velocity is very less, but still you will hear that sound. You see, this is that vibration, that musical sound. Okay. So, in summary, TCD is an excellent bedside tool for screening vasospasm. Moreover, it can be repeated very frequently, non-invasive, and it gives a real time. And waveform pattern, not just the number, gives more meaningful information. But it is not suitable for distal vessels where it's very difficult to see. The limitations can be technical factors, patient factors. Sometimes the decompressive craniotomy has been done. So there is no, then the purpose of TCD is lost. Okay. And then if there is a tandem CVS, if the vasospasm occurs at 2 or 3 different segments in the same blood vessels, then this numerical criteria might not hold true. Thank you.
Thank you, sir, for that enlightening session. Next up is a very deeply relevant and often life-saving application, that is TCD in TBI, raised ICP, and brain death assessment. It is our privilege to welcome Dr. Amit Goyal, a distinguished name in the field of neuroanesthesia and neurocritical care. Dr. Amit, sir, currently serves as a senior consultant at Akash Healthcare, Delhi. With a focused interest in neuromonitoring, neurocritical care, and interventional pain management, Sir has contributed significantly to advancing patient-centered, precision-based neurological care. Please join me in welcoming Dr. Amit Sir to share his expertise.
Good morning, everyone. This session is about the role of transcranial Doppler in traumatic brain injury, raised ICP, and the brain death. By now, you all know that TCD provides a direct window to the brain circulatory dynamics, and these dynamics, they changes into these 3 pathologies. So that's why TCD can be useful to assess these patients when tools to direct access the brain are not available. Since ICP is common to both TBI and the brain death, I'll be covering the role of TCD in ICP first. Transcranial Doppler, it has certain advantages over the standard, more accurate but invasive tools such as EVD or parenchymal monitors. But it has certain advantages because it is non-invasive, it is inexpensive, it has no associated risk of infections, hemorrhages. It can be used in patients with the coagulopathy. Therefore, non-invasive estimation of ICP, it is valuable in these patients in whom the invasive monitor tools are either unsafe or these tools are not available. Since the basal cerebral arteries, they has compliant walls, they are more vulnerable to the external pressures with the ICP. And this ICP, it causes then change to the flow velocities and the spectral waveform analysis, which can be non-invasively observed with the transcranial Doppler. So the TCD-based non-invasive ICP estimation is based on 3 things. First one is the pulsatility index. Second is the waveform changes. And the third is the mathematical model, such as one provided by the Belnar et al., which gives a ICP value within a range of 5 to 40 millimeter of mercury with the sensitivity and specificity of almost 90%. Now, what is this pulsatility index? This is the numerical representation of pulsatile character of the blood vessel in respect to the downstream resistance. So it is calculated with the formula, the numerator here has the difference between the systolic flow velocity and the diastolic flow velocity, and the denominator here is the mean flow velocity. So whenever there is increase in the downstream resistance, the first thing which happens is the decrease in the diastolic flow velocity, increasing the difference between systolic and diastolic velocity, thus increasing the numerator here. So a value of PI more than 1.2 is suggestive of increase in the downstream resistance, which is usually seen in the conditions with raised ICP or brain death. Now, how do we make out the changes of the spectral waveform with respect to the raised ICP? I said the first thing which happens with the raised ICP is the reduction in the diastolic flow velocity. So there will be reduction in the diastolic flow velocity, which is seen as diastolic blunting. And once ICP increases further and it crosses the diastolic blood pressure, there will be reversal of flow during the diastolic phase. With further increase in the ICP when it approaches the systolic blood pressure, there will be further reduction in the systolic flow, forward flow during the systolic phase, which you can see here. This is known as the short systolic spikes. And in the extreme cases, you will see total absence of the flow signal, that is known as the circulatory arrest. Here you can see, this is a normal TCD spectral waveform. Here you can see this has a sharp systolic upstroke, a peak systolic velocity, a gradual downstroke with a dicrotic notch, and diastolic flow velocity, which is almost 1/3 of the peak systolic velocity. This is the normal one. But when ICP starts increasing, the systolic peak velocity initially increases to compensate, and it has a very sharp, rapid upstroke. And the diastolic velocity here, it decreases, known as the diastolic blunting. With further increase in the ICP, when it crosses the diastolic blood pressure, there will be reversal of flow during the diastolic phase. That is known as the diastolic reversal. And once it approaches the systolic blood pressure, the forward flow during systolic phase also reduces, giving rise to the short systolic spikes. Now, this is an example of a case which shows the role of TCD in real clinical scenario. This was a 33-year-old male who was admitted to our hospital with complaint of severe headache and neck pain. After reaching the ER, that fellow had one episode of GTCS, after which his GCS dropped. His GCS was E2, V2, and M4, and his systemic parameters revealed accelerated hypertension, which was resistant to the labetalol infusion. His CT scan was done, which revealed large intracranial right-sided hemorrhage, and he was shifted to the ICU because there was some time before he could be shifted to the OT. A rapid TCD examination was done, which revealed short systolic spikes and diastolic blunting on the right MC flows and the right AC flows, and the left side MC flows were pretty normal. Immediately, ICP lowering maneuvers were initiated. Patient was sedated, intubated, and hyperventilation was initiated along with additional dose of mannitol. This was, the effect was quite visible with sudden improvement into the systemic parameters, and a quick TCD was repeated after 10 minutes, which showed improvement into the right-sided MC flows, just similar to the contralateral side. So this case, it shows the role of TCD in identification of the ICP as well as the management of the patients in that particular window when patient was waiting to be shifted to the OT. Now, next is the role of transcranial Doppler in the TBI. Transcranial Doppler in the TBI can be used to assess the cerebral blood flow and as well as to track these changes with respect to the interventions such as osmotherapy or hyperventilation. Therefore, it can be used to guide the therapy as well in these patients. It can be used for the estimation of non-invasive ICP, as I discussed earlier. It can also be used to identify patients with impaired autoregulation, which is an obvious sign of raised ICP. It can be used for the early detection and monitoring of patients who may have traumatic ICA dissections and prognostication of patients with severe traumatic brain injury. Now, the TBI, it leads to different phases of cerebral blood flow over different phases of the time period. TBI may lead to hyperperfusion on day 0. It may lead to hyperperfusion on day 1 to day 3, and it may have vasospastic phase from day 4 to day 15, just similar to the SAH. So TCD may be helpful in diagnosis these phases and manage the patient accordingly. It can be used for non-invasive estimation of ICP. Just a quick review. The pulsatility index, it will increase. The waveform changes. Initially, there will be diastolic blunting. Once ICP starts increasing further, there will be flow reversal. After that, there will be short systolic spikes. TCD can also be used for the prognostication of patients with severe TBI. On the first day, within the first 24 hours, if diastolic flow velocity is less than 20, it is associated with high PI, and there is also impaired autoregulation. These are signs of poor prognostication. And within the next 72 hours, a low flow MCA velocity of less than 35 has shown to be poor prognostic indicator for the outcome at 6 months. Now, the TCD can also be used for early detection and monitoring of patients with traumatic IC dissection. Usually, the bedside tool to diagnose these patients, to screen these patients, is the normal duplex ultrasonography, which will reveal what happens. Basically, what happens in the traumatic IC dissection, there is separation of the intimal wall and there is collection of the blood in that walls. So this hematoma, it actually compresses the normal lumen, causing stenosis. So what happens on duplex sonography, you'll find reduction in the systolic flow velocities, and occasionally you may also find the intimal flap. But the problem with the ultrasonography here is it has a limitation that usually the segment of the traumatic IC dissection is at the skull base. So sometimes you may not be able to insonate the dissected segment. So here the TCD insonation of the MC on the same side comes into help. What it will reveal is, since it is causing the IC dissection is causing stenotic flow, so the MCA flow velocities will be reduced here, and you will see a difference of more than 25% compared to the contralateral MCA, and this will be associated with reduced PI. Why PI will be reduced? Because the MCA here is the segment distal to the dissected segment, stenotic segment. So it will be, to compensate the flows, it will be dilated. So the PI will be reduced. And occasionally one may also find the microembolic signal known as the HITS, hyper intensity transient signals. These are two case scenarios which I have borrowed from a friend for this workshop. First one is a 48-year-old male with severe traumatic brain injury. When he was admitted, immediately after admission to the ICU, they performed transcranial Doppler, which revealed low end diastolic flow velocity of 21 and high pulsatility index of 1.33. Immediately after this, they started resuscitation, and they increased the mean blood pressure along with initiation of osmotherapy. But this resulted in transient increase into the end diastolic flow velocity from 21 to 34 and a reduction into the PI from 1.3 to 0.8. But despite these correction and improvement in the flow velocities, patient had deterioration in the neurological status, and he was wheeled into the OT for decompressive craniectomy. And after craniectomy, there was significant improvement in the flow velocities. Both the peak systolic flow velocity and end diastolic flow velocities are good, along with normalization of the PI with 0.7 value. Just a second. This is another case. This was a 38-year-old male with right-sided EDH and scalp hematoma. Because of the EDH, the TCD examination was performed from the left side. Here you can see initially the left side vascular insonation was possible, but vessels on the other side, the right side, could not be insonated. Since patient, the GCS was low, patient was taken to the OT for decompression, and even after the OT, the sensorium was, the GCS improved, but still altered sensorium was persisting. They repeated the TCD examination, and still TCD examination was same. The insonation of the opposite side vessels was not that great. So after discussion with the surgical team, they initiated the osmotherapy, and after that there was improvement in the patient's clinical condition as well as improvement in the insonation of the opposite vessel as well as the spectral waveform. Now coming to the TCD in brain death, since the development of organ transplantation programs in India, diagnosis, the interest in the diagnosis of brain death has increased significantly over the past decades. So what is brain death? Brain death is irreversible loss of clinical functions of the brain and brainstem. What is the role of TCD in diagnosis of brain death? It helps in the establishment of cerebral circulatory arrest. But for this, you require to insonate to assess both the circulation, anterior circulation and posterior circulation on both the sides, with at least 2 evaluations 30 minutes apart. So again, a revision. What are the phases of cerebral circulatory arrest? First, you will see diastolic blunting. In the second phase, when ICP starts increasing, ICP is more than the diastolic blood pressure, there will be flow reversal during the diastolic phase. In the next phase, this flow reversal will be equal to the forward flow during the systolic phase. So the next current, the net forward flow will be 0. Here, the ICP is more than the cerebral perfusion pressure. So the net flow will be 0. In the next phase, there will be total absence of the flow signals, but you have to make sure that you have to rule out that it is not the absence of window. You are not performing the TCD for the first time. The absence of the flow signal can be tagged only if there was previously established flows through the same window. What are the limitations of TCD? for the diagnosis of brain death. First one is the inadequate insonation, that is because of poor window. Second is the lower sensitivity than the clinical examination. Then it may also give you false negative results, that is persistently present flows even in the brain death patients. What are the conditions? Conditions are the abnormality into the cranium, such as decompressive craniectomy patients, malleable cranium of the infants and young children, and in patients who are brain dead because of brainstem injuries. And it may also give you false positive results because in conditions such as refractory high ICP and immediate post period of the post cardiopulmonary arrest, because the diagnosis of cerebral circulatory arrest is common in these two conditions as well. But remember that the cerebral circulatory arrest in these two conditions is transient and reversible, whereas it is irreversible into the brain death condition. This is one case scenario. A 63-year-old male came to our hospital with sudden loss of consciousness in the morning. On arrival, his GCS was E1, M2, and V2, and his pupils were bilaterally dilated with non-reactivity to the light. His vitals were quite stable, and he was taken for emergency decompressive craniectomy in view of this large right-sided intracranial hemorrhage with intraventricular hemorrhage. In the immediate post-operative period, patient was showing sign of bradycardia, and his GCS was E1, M1, and VT, and pupils were still 4 mm non-reactive to light. His brainstem examination was done, which shows absent brainstem reflexes. His TCD was performed, which revealed flow reversal here. You can see here that the flow reversal is equal to the forward flow in the systolic field. So the net flow will be 0 here, and you can see the bradycardia. Then post-op CT scan was repeated, which showed loss of gray white matter differentiation along with the white cerebellar sign. And patient was diagnosed as brain dead patient. So to conclude, TCD may not be the ideal or the gold standard diagnostic tool for these pathological conditions, but it definitely adds value to the diagnosis, and the serial measurement or the trend of the TCD value definitely adds value to the patient therapeutic interventions, as well as it can also predict patients who are at risk of deterioration. Thank you.
Thank you, sir, for a detailed and a clinically useful talk. For our final topic this morning, we now delve into TCD in cerebral autoregulation, a sophisticated yet fascinating domain. Please welcome Dr. Ravi Srinivasan joining us from the UK. Dr. Ravi Srinivasan, sir, is a consultant neurologist and consultant critical care physician at St. George and St. Helier University Hospitals, London. With a deep interest in neuromonitoring, multimodality monitoring, and the interface of neurology and internal medicine in critical care, Sir's work focuses on advancing outcomes in non-traumatic brain injury and enhancing the role of EEG monitoring in neurocritical care settings. I now welcome Dr. Ravi Srinivasan, sir, for his valuable talk.
First of all, I'd like to thank the organizing committee for inviting me all the way. It's a good thing to see old friends as well as new friends. And a lot of academic stuff has been going on. I don't want to take too much of your time before lunch. It's good in a way, but bad in a way, because I know there's some who are online also. Good in a way because many of the information I'm going to give you, all the experts have already told you. I can actually say good morning and thank you and go home now. Bad in a way because you've all said everything. What am I going to say extra? I don't know. So I'm a bit worried now. So I'm not. Some of the information I'm going to give you is going to be a bit of a repetition. So sorry for that. Yeah. So I'm just a simple physician who works in intensive care, does a lot of examination of the patient. I'm not a technology person. I'm a clinician, and I'm not AI for the people online. I do exist. I am a real person. So this is just an hello from my friends. So I know all of us are used to technology with different information like ICP bolts, transcranial Dopplers. You heard, EEG monitoring, depth electrodes, all kinds of stuff, venous saturations, all those things. And then equally, what are we trying to do with all these things? All we're trying to do is prevent secondary brain injury. The primary injury is done, finished. You cannot change it. So your job now is to only for secondary prevention. So yes, all this is going to give you information, but you're the human supercomputer to decide whether that information is correct, whether that information is applicable to that patient, or whether that patient is actually the right patient, or it might be a completely wrong entry, because there are reports coming. The patient is in one hospital, the report happens in another hospital. So you need to be careful on all those kind of things. So I'm just giving you all practical problems what I face. Okay. So I'm just going to go through a few things, but just bear with me for a few minutes. So as Amit was saying, the main idea is to anticipate, predict the deterioration, recognize the abnormality, support goal-directed intervention, and actually prognosticate the patient. Because what ultimately we're trying to do is to prognosticate along with our clinical care. Why do we monitor? Obviously, we want to detect it as early as possible. And obviously, what we have found is that any single fluctuations in ICP can actually be even a small fluctuation, or it can be a sustained element. So our next problem starts, how long do we monitor these patients? Is it just a one-off monitoring or for a day or two, or is it then a few more days? How long do you keep them in intensive care? How do you prognosticate them? So that's a big thing. I don't know. Fortunately, in the UK, I survived because the NHS takes care of the element of financial problems. Whereas in India, I'm sure there's going to be an element of where the patient's family are going to ask you, is it worth doing all these investigations? And I've been given the most difficult topic because all the nice words were all said by the good people. But what's auto-regulation? So auto-regulation is nothing but you want to keep the flow constant and you want the cerebral blood volume to be constant. Anything changes, raises your ICP. That's all. Okay. So plain and simple, anything which affects injury in the form of any form, intracranial, extracranial, it's going to cause changes, and brain injury automatically is going to affect your autoregulation. So the most important thing is anything, oh, sorry, this one is the pointer. Yes. Yeah. So anything happening to oxygen, carbon dioxide, and anything happening outside is important, because all that you want to keep it in this area where the lower limit and the upper limit of autoregulation is where you're trying to keep it, and your vascular resistance has to be in a maintained state. Now the problem is, where do you know where you are? You can be here at one point of the day at 9 o'clock in the morning. You can be at 11 o'clock in the afternoon here, or you can be here at 1 o'clock in the afternoon. So the most important thing which I want you to take home today is doing the investigation of TCD, as what was said earlier, is not important. You need to be consistently standing there, repeating it for the same patient so that you understand the trend of how it is happening. Now, as soon as the insult happens, all this goes into the bin. There's nothing, this part of what we're saying as sustained autoregulation within this area is gone. And as soon as acute insult happens, you've got this happening, that everything changes. Now, you know that any fluctuations in your, any fluctuations in your blood pressure can have a waveform variation in your cerebral blood flow also. So you find that the more the injury, with head injury, once your blood-brain barrier is broken and once your autoregulation is thrown in the dustbin, automatically you've got a higher vulnerability. And as you know, the sympathetic nervous system decreases the blood flow, parasympathetic increase the blood flow. So anything you do, you like your noradrenaline in intensive care, I know that, but you're going to cause more problems. Okay, so be careful of that. Because what you're causing might be the actual end result, and you may be calling it as loss of autoregulation, loss of, as what Amit was saying, the variations in PI and all the kind of things we have to break our head on afterwards. Now, another important thing is there are, as we said earlier, intermittent ways of doing it, like the TCD, but the problem is the limitations of how often do you do it, how many times you do it, and whereas if you do a continuous monitoring, for example, like tissue oxygen monitoring or a nurse or an ICP with a PRX kind of setup, the problem is it's where do you keep, for example, if you do a tissue oxygenation, even like 1 centimeter, we want to hit the periregional injury as the maximum point. But the problem is when you have a multi-modality monitoring, and if you miss that 1 centimeter area and you put it somewhere else, you are actually going to get a wrong value. So you think the patient is fine and you've missed the window. So just be careful when you ask for certain investigations and how you place it. And of course, we know PRX is useful because you want to optimize your cerebral perfusion pressure based on the patient, and you want to adjust the optimal CPP for the patient. But then, of course, you got TCD indices, which we use, which we can decide for autoregulation. You can decide with the PRX, anything negative is better, positive is bad with the variation. But the problem is you need to be there specifically to understand that every time you assess the patient, I actually combine all three together, and I'll come to that before I say something. But there are a lot of random trials going on with regards to comparing it, and specifically, for example, in traumatic brain injury, as we discussed earlier. And the lower the CPP, the more is the dangerous risk that you're going to, it's basically a problem. And you always like to have a higher CPP, but please note that that is not necessary and the complications are higher. I'm just going to skip this because I know you heard this through the day in the morning, but be careful of where you keep the probe, how much is your depth, what is your assessment. Just skip this slide also. And this was what I was telling you. The mean flow index you can calculate with the cerebral blood flow, and it actually gives you a good index and a correlation for autoregulation. And you can then see if you got a mean flow index of high positive correlation of more than 0.7, it automatically says that you're getting into a trouble zone of impaired autoregulation. You do have various parameters TCD driven, for example, the mean flow index, the systolic component, the diastolic component. The systolic is better than the diastolic because of the utility wise, it's better. But equally, you have to assess with regards to other areas, like for example, in stroke, whether there's an ipsilateral or contralateral variation. With that, you can decide whether there's associated autoregulation changes. But the problem is, all these informations or what we have is very specific to certain centers. It's not actually, it's all extrapolated information what we have from certain centers. Like for example, in Addenbrooke's, we used to do that. And we found that once you do the TCD, it's actually a good predictor for autoregulation impairment, and your mortality changes as soon as you have an intact cerebral autoregulation, your mortality is low, whereas your impaired autoregulation, automatically your mortality risk goes up. So when you talk to patient's family, you can start telling them what the risks are. This is just another example where when we do monitoring with mean flow index as well as it's a combination of TCD plus everything put together, you find that straight away there's always a bad trend when it comes to an abnormal mean flow index. I think I'll just skip this slide. It's not, or actually, yes. I want to just say one more thing, that with regards to, for example, when you get a bad autoregulation and you find that any rise in your ICP, sorry, can you see that? Yeah. Any sustained rise in ICP is better tolerated when you got a good autoregulation. But when you got an impaired autoregulation, ICP is going to be impaired. So therefore, automatically, it affects your prognostication outcomes. And this is just a quick example of what a normal autoregulation looks like when you're doing a beat-to-beat variation TCD assessment. The top one is the normal one, whereas here you can see that the lower one is where the autoregulation is impaired. So this is just a continuous TCD monitoring use. And now a quick word about autoregulation doesn't finish without me mentioning about vasomotor reactivity, which is very important. And also there's a lot of studies about breath holding index. I'm sure you would have heard of all that, and you probably doing it anyway. It's very much important, but I find that breath holding index does only the parasympathetic system, and it's only a vasodilatory reserve, whereas the vasomotor reactive test is actually both sympathetic and parasympathetic. So I find it more useful to assess into it. This is just an example that when you have variations, it's a higher risk that your autoregulation is becoming impaired. Of course, there are a lot of CO2 studies. You would have seen this in the past, where they assess over time CO2 retention and see what happens to the flow rate, flow velocities, and then they compare it to the outcomes. Other areas where autoregulation is affected, of course, is your subarachnoid hemorrhage, acute ischemic stroke, and I've also used it in children with moyamoya disease and sickles. So these areas I've also found it very useful. And of course, the whole idea is to have a guided management, and there are a lot of limitations and trials are going on. One size doesn't fit everybody, so you have to be careful when you generalize your statement and you actually do it for a particular patient. It may not work in that particular patient. And so also just to be aware, the autoregulation is dynamic and it varies from time to time. So what you find in the morning and when you do your ward rounds and you say everything is fine, is gone in 2 minutes time later. So just be careful, and you need to monitor it and tailor it to optimize the therapy. I hope I've said as much as fast as possible in the last 15 minutes.